Welcome back to the Deep Dive. Today, we are taking on a huge, and I mean a really high-yield, topic for anyone in nursing: pediatric endocrinology. We're going to fuse all those notes and practice questions into a focused masterclass on growth, water balance, and metabolism.
Exactly. And this isn't about just, memorizing a list of symptoms. We're going deep into the clinical reasoning, the why behind everything. Because once you get the pathophysiology, the NCLEX questions, they just start to make sense.
That's the mission. A compressed masterclass covering etiology, the hallmark signs, and most importantly, the prioritized management for growth disorders, those really tricky ADH imbalances, and of course, the critical steps for DKA.
Right. We need to internalize the logic. So
Right.
why do you pick one fluid over another in DKA? Why is the timing of a growth hormone shot so important? That's what we're digging into today.
Okay, let's start where a lot of these cases start in the real world, with a physical sign that brings a family into the clinic. Let's unpack this.
Sure.
Starting with growth, and specifically short stature. When a child presents with short stature, my first thought is maybe growth hormone deficiency. But the notes make it clear that's often a mistake.
It is. That's a huge pitfall. The first thing you have to realize is that most of the time, it's not pathological at all. The most common reasons are things like constitutional growth delay. That's just your classic late bloomer,
Okay.
the kid who's going to hit their growth spurt later than their friends. And then you have familial short stature, which is just genetics. The child's height is pretty much what you'd predict from their parents' height. These are just normal variations.
But then we get into the actual hormonal issues, the stuff where the pituitary gland is involved. So besides GH deficiency itself, what other endocrine problems can stunt growth?
Well, you have to think about the whole system. First up is the thyroid. If you have untreated hypothyroidism, everything slows down. The whole metabolism is sluggish, and that includes the rate of physical growth.
And what about cortisol?
Yes, cortisol excess. So in a condition like Cushing's syndrome, the body is just flooded with cortisol, and cortisol is catabolic, meaning it breaks things down. It breaks down muscle, it breaks down bone, and it actively blocks growth hormone from working at the growth plate.
Okay, so it's directly interfering. The notes also mention chronic systemic illnesses. And it's more than just the body being tired, right? There's a deeper mechanism.
Absolutely. Think of it this way. The body's number one priority is survival. Growth is a luxury. So if a child has a severe chronic illness like renal failure or a serious heart or lung disease, the body diverts all its resources to just staying alive.
Let's drill down into chronic renal failure, because that seems to come up a lot. Why does that specifically stop growth?
It's a double whammy. First, the damaged kidneys can't properly activate vitamin D, which you need for healthy bones. But the real high-yield point, the thing to remember for an exam, is that those uremic toxins and the chronic inflammation, they stop the liver from producing something called IGF-1.
And IGF-1 is?
Insulin-like growth factor 1. It's the main messenger for growth hormone. So the pituitary might be screaming out GH, but the signal never gets through because the liver can't produce the IGF-1. The problem isn't the pituitary, it's the target organ.
That's a key distinction. And of course, there are genetic causes.
Right. Classic NCLEX examples are Turner syndrome in girls, where there's a missing X chromosome, or Down syndrome, trisomy 21. Both have specific developmental patterns that affect bone growth.
And the last one on the list is fascinating: psychosocial dwarfism.
Yeah, this really shows you the power of the mind-body connection. Extreme stress, neglect, it causes a chronic release of cortisol. And that stress chemically disrupts the natural nighttime release of growth hormone. The child's growth just pauses.
So with all these possible causes, how do you actually diagnose true GH deficiency? What are the key tests?
You have to work through it systematically. The first thing you'll do is a screening test. You measure your levels of IGF-1 and something called IGF-BP3.
Why not just measure GH directly?
Ugh, that's a common trap. You can't. Growth hormone is released in these short, intense bursts, mostly when you're in deep sleep. So if you did a random blood draw during the day, the level would probably be 0, even in a healthy person. A single measurement is useless.
So the screening points you in the right direction. What's the definitive test?
It's called provocative growth hormone testing. We actually give the child a medication like insulin or arginine that is designed to stress the system and force a big release of GH.
Pharmacological stress test.
Exactly. And if the GH level still doesn't rise above a certain point, even with that strong stimulus, then you've confirmed a deficiency. That's the gold standard.
And while you're doing that, you'd also want to look at the pituitary itself.
Of course, an MRI of the pituitary is standard to check for any structural problems, like a tumor or a congenital defect that could be causing the issue.
Okay, and what about the bone age X-ray? That seems like a classic.
It's a favorite on exams. You take an X-ray of the child's left hand and wrist, and what you're doing is comparing their skeletal maturity, how open or closed their growth plates are, to their actual chronological age.
And what does that tell you?
If the bone age is much younger than their real age, it suggests there's a delay in maturation. But that's also good news because it means there's still time and potential to grow if we intervene.
And you'd also run specific labs to rule out those other causes we talked about.
You have to. You do a karyotype for a girl to rule out Turner syndrome. You'd check thyroid function. You'd check cortisol levels for Cushing's. And if you suspect malabsorption, you'd check for celiac disease antibodies.
Okay, let's switch to signs and symptoms. For a child with GH deficiency, what's the one physical finding that differentiates it from other forms of dwarfism on an exam?
This is the single most important point. The child with GH deficiency has normal skeletal proportions for their age. They look like a perfectly proportioned, just smaller version of another child.
So they're not disproportionate like with achondroplasia where the limbs are short.
Exactly. That's the key differentiator. They're proportional. Their growth is usually normal for about the first year, and then it just decelerates. It falls off the growth curve. But their intelligence is usually totally normal.
Now let's flip it. What about too much GH? Hyperpituitarism?
Here, the critical distinction, the thing the exam will test you on, is timing. It all depends on whether the excess GH started before or after the growth plates close.
Okay, so if it starts before they close.
That's gigantism. The long bones are still active, so the child has this massive overgrowth. They become extremely tall with large hands, feet, and facial features.
And if it happens after the plates have already fused, like in an adult?
That's acromegaly. They can't grow taller, so the bones thicken and widen instead. You see this pronounced growth in the jaw, the brow, the hands, the feet, but their height doesn't change. That timing is a classic NCLEX question.
So if we've confirmed GH deficiency, the treatment is synthetic GH, somatropin. What are the key nursing rules for administration?
It's a daily subcutaneous injection, so a lot of family education on technique, rotating sites. But the most crucial part, the real physiological hook, is the timing. It has to be given at bedtime.
And why at bedtime?
Because you're mimicking the body's natural rhythm. The body's own GH peaks during deep sleep. Giving the injection at night synchronizes it with the body's normal metabolic cycles and gives you the best possible effect.
And this isn't a lifelong therapy. When do you stop?
You stop when the growth plates have closed and they're not going to grow anymore. The specific criteria are when their growth slows to less than an inch per year, and either bone age is about 14 for girls or 16 for boys.
And the nursing care goes beyond just giving shots.
Oh, absolutely. There's a huge psychosocial component. These kids can be teased. So the nurse's role is to assess how they're coping, to build their self-esteem, and really support the family through a long-term treatment plan.
For GH excess, the treatment is more direct. It's about getting rid of the tumor.
Right. It's almost always surgical. The goal is to remove the pituitary adenoma that's overproducing the hormone. Sometimes it takes multiple surgeries or even radiation to get those GH levels back to normal.
Okay, let's pivot to one more pituitary issue. Precocious puberty? This is when puberty starts way too early, right?
Yeah.
Before age 8 in girls and 9 in boys.
Exactly. And the most common type is central precocious puberty. This means the whole brain-to-gonad system just turned on too early. It's a premature maturation of the entire axis.
So besides the social awkwardness, why is this an urgent medical issue? They're growing fast. Isn't that a good thing?
Ah, but that's the trap. It's deceptive. Yes, they get an early growth spurt and get tall quickly. But those same-sex hormones also cause the growth plates to mature and close way too fast. So they stop growing prematurely, and their final adult height ends up much shorter than it should have been.
So the goal is to hit the brakes on puberty to save their final height. How do you do that?
We use a synthetic version of gonadotropin-releasing hormone, a GnRH analog. It's usually a monthly injection.
And how does giving a hormone actually stop the process?
It's a really cool mechanism called downregulation. You're giving the pituitary a constant high-dose signal instead of the normal pulsatile one. The pituitary's receptors get overwhelmed and they just shut down. They become desensitized.
So it stops the pituitary from sending out the puberty signals, LH and FSH.
Precisely. It effectively pauses the whole process, giving the child's bones years to grow normally until you stop the medication and allow puberty to resume at a more appropriate age.
That's really clever. Okay, we've covered the pituitary's control over growth. Now let's move to the posterior pituitary and how it controls water balance. This is the classic showdown between DI and SIADH.
The ultimate dry versus wet paradox. And if you can just remember which one is which, too little ADH or too much ADH, all the interventions just fall into place.
Let's start with diabetes insipidus, or DI. The problem here is not enough ADH action.
Right. DI means you can't concentrate your urine, so you're losing massive amounts of free water. There's central DI, where the pituitary isn't making enough ADH, usually from head trauma, surgery, or a tumor.
And the other type?
Is nephrogenic DI. That's a kidney problem. The pituitary is making ADH just fine, but the kidneys aren't listening. They're resistant to it. For exams, a high-yield cause of this is lithium toxicity.
Okay, so that's DI. Now the polar opposite, SIADH, syndrome of inappropriate antidiuretic hormone.
Here, the body is flooded with ADH. The feedback loop is broken. ADH keeps being released even when it shouldn't be, forcing the kidneys to reabsorb tons of water. You end up with fluid overload, water intoxication, and severe dilution of your electrolytes.
And the causes are usually related to the brain, right?
Almost always. Things that irritate the CNS. Meningitis, brain tumors, head trauma. The takeaway is you're retaining a ton of water, but not the sodium to go with it.
Let's nail the signs and symptoms. For DI, the dry patient, what are we seeing?
You're seeing the classic triad. First, polyuria, and I mean extreme. Up to 20 liters of urine a day. That leads to polydipsia, an intense, unquenchable thirst. And in kids, the very first sign is often enuresis or new-onset bedwetting.
And their labs and vitals would reflect that massive fluid loss.
Exactly. They'll be tachycardic, maybe hypotensive. Their urine will be incredibly dilute, so a very low specific gravity, like less than 1.005. But their blood will be super concentrated, so you'll see high sodium or hypernatremia.
What about for an infant? They can't exactly say they're thirsty.
That's the subtle clue. An infant who is suddenly extremely irritable, not feeding well, and has tons of really wet diapers. That should be a huge red flag for DI and severe dehydration.
Okay, now SIADH, the wet patient. What's the hallmark here?
The hallmark is water intoxication, and because of that, dilutional hyponatremia. Low sodium. Physically, you'll see weight gain, maybe some crackles in the lungs, and very low urine output.
But the real danger isn't the fluid overload, it's the low sodium, isn't it? The neurological signs.
That is the red flag. Absolutely. When sodium in the blood gets too low, water shifts into the brain cells, causing them to swell. Early on, you might see nausea and vomiting, but it quickly progresses to confusion, lethargy, and then seizures.
And the life-threatening complication is cerebral edema.
Hyponatremic encephalopathy. It's a true medical emergency. And the labs are the complete opposite of DI. The blood is dilute, low sodium, low osmolality, but the urine is super concentrated with a high specific gravity because the ADH is forcing the kidneys to hold on to every last drop of water.
Okay, so let's talk management. For DI, the dry patient, the priority is fluid.
Yes, you're monitoring INO like a hawk, but here is the #1 NCLEX rule.
Yeah.
You do not restrict fluids on a patient with untreated DI. Their thirst is the only thing keeping them from becoming dangerously dehydrated.
So for central DI, we replace the hormone with desmopressin or DDAVP.
Correct. DDAVP acts just like ADH and tells the kidneys to start reabsorbing water again.
Now here's a critical safety point. What happens once the patient starts getting DDAVP? The rules change, don't they?
They completely flip. This is so important. Once you give DDAVP, the patient can no longer pee out excess water. So if they keep drinking the huge volumes they were used to, you can push them from DI right into an iatrogenic or medically induced SIADH.
You can make them water intoxicated.
You can, and they'll get hyponatremic. So once DDAVP is on board, you have to monitor them closely and usually restrict their fluid intake to a normal level to prevent that from happening.
Okay, what about nephrogenic DI, where DDAVP won't work?
For nephrogenic DI, the management is a low-salt, low-protein diet and, paradoxically, a thiazide diuretic.
Great, a diuretic for a patient who is already losing too much fluid? That sounds wrong.
I know, it's counterintuitive. But the thiazide causes a mild dehydration, which tricks the first part of the kidney tubule into reabsorbing more salt and water. This means less fluid ever makes it down to the end of the tubule, the part that's resistant to ADH. It effectively reduces the total urine output.
That's a great explanation.
Oh.
Okay, now for SIADH, the wet patient, the intervention is the opposite.
Step 1, 2, and 3 is fluid restriction. It is the absolute primary intervention. You're trying to let the body concentrate its sodium levels back to normal. We monitor daily weights. That's the best indicator of fluid status.
Are there any medications?
You might use diuretics to help get rid of some of the free water. And in some cases, a drug called dimeclocycline, which actually blocks ADH from working on the kidneys.
And for that emergency situation, the hyponatremic seizure.
That's when you bring up the hypertonic saline, 3% NiCal. You have to give it very, very slowly and carefully. It works by pulling that excess water out of the swollen brain cells. But if you correct the sodium too fast, you can cause a different, terrible neurological injury called osmotic demyelination. So slow and steady is key.
So the big takeaway, DI is low ADH, needs fluids, and DDAVP, SIADH as high ADH, needs fluid restriction.
You got it.
All right, let's move to our final major topic, the pancreas and diabetes mellitus. Let's start with the basics, type 1 versus type 2.
Sure. So type 1 diabetes is an autoimmune disease. For reasons we don't fully understand, the body's own immune system attacks and destroys the beta cells in the pancreas. The result is an absolute deficiency of insulin. They make little or none.
And that absolute lack of insulin is why DKA, beta-ketoacidosis, is so common in type 1.
Exactly. Without insulin, glucose can't get into the cells for energy. The body thinks it's starving, so it starts burning fat for fuel. The byproduct of that is ketones, which are acidic, and that's what leads to DKA.
In contrast, type 2 diabetes is more about resistance.
Right. In type 2, the pancreas is usually still making insulin, at least at first. But the body's cells, the muscle and fat, they don't respond to it properly. They're insulin resistant. It's a much more gradual onset, and while they can get DKA, it's much less common than in type 1.
Okay, let's cover the classic signs of diabetes. The 3 Ps.
Right. Polyuria, frequent urination, because the glucose is spilling into the urine and pulling water with it. Polydipsia, increased thirst because of all that fluid loss. And polyphagia, increased hunger, because even though there's tons of sugar in the blood, it can't get into the starving cells.
Now for the acute emergencies. First, hypoglycemia. Low blood sugar, what does that look like?
Hypoglycemia comes on fast. You'll see adrenergic signs first. The body releases adrenaline, so they'll feel shaky, weak, sweaty, they'll look pale. Then, as the brain gets starved of glucose, you see the neuroglycopenic signs. Confusion, difficulty speaking, poor coordination.
And the other extreme, DKA. What's the definition?
DKA is a triad. Severe hyperglycemia blood sugar, usually over 200, some say over 330 plus metabolic acidosis, and ketones in the blood or urine.
And what are the physical signs of that acidosis?
Well, they'll be lethargic, maybe confused, nauseous. But the two hallmark signs are respiratory. The body is trying to blow off the acid as CO2, so you'll see these deep, rapid breaths called Kussmaul respirations.
And the other one?
The other is the fruity breath. It's the smell of ketones, specifically acetone, being exhaled. It smells a bit like nail polish remover. If you smell that, it's a dead giveaway for DKA.
Okay, this next part is maybe the most important sequence we'll discuss. A child comes in with DKA. It's an emergency. What is the absolute non-negotiable first step in management?
Fluids. 100% of the time, fluids first. These patients are profoundly dehydrated. You start with an IV bolus of 0.9% normal saline. You must restore their circulatory volume before you do anything else.
Why is it so dangerous to give insulin before you give fluids?
Because of potassium. Giving insulin immediately shoves potassium from the blood back into the cells. The DKA patient is already low on total body potassium, even if their serum level looks okay. If you give insulin first, you can cause a sudden catastrophic drop in their blood potassium, which can lead to a fatal cardiac arrhythmia.
Wow. Okay, so fluids are running. What's the very next thing you do?
You immediately get them on a cardiac monitor. You have to watch for EKG changes from those potassium shifts and pulse oximetry, and you start frequent neuro checks.
So when do you actually start the insulin?
Insulin is step 3. It starts after that initial fluid bolus, and it's always an IV infusion of regular insulin. That's the only type you can give IV. You start it at a slow, steady rate.
Okay, let's talk more about potassium. We know they're depleted. When is it safe to start replacing it in the IV fluids?
There are 2 critical safety checks. 1, you have to be sure the child is voiding. You need confirmation that their kidneys are working so they don't become hyperkalemic. And 2, it's only after the initial fluid and insulin has started.
Okay. And the last piece of the puzzle is dextrose. Why would you add sugar to the IV when you're trying to bring the sugar down?
This is all about preventing the most feared complication of DKA treatment, which is cerebral edema.
Okay, walk me through that mechanism.
When the blood sugar is sky high for a while, the brain cells get used to that hyperosmolar state. If you drop the blood sugar in the body too quickly with insulin, water will rush from the bloodstream back into the brain cells, following that osmotic gradient. The brain cells swell, and that can lead to herniation and death.
So you add dextrose to the IV fluids once the blood sugar gets down to about 250 or 300.
Exactly. Adding that dextrose allows you to continue the insulin infusion to correct the acidosis without letting the blood sugar drop too precipitously. It creates a much gentler landing, protecting the brain. The whole rehydration and correction process should be done slowly, over about 48 hours.
That sequence and the why behind it is absolute gold. Okay, let's shift to daily management. Insulin injections, does it matter where you give it?
Oh, absolutely. The absorption rate is very testable. The abdomen has the fastest absorption, then the arm, then the leg, and the buttock has the slowest absorption rate, but the longest duration. Rotating sites is key to prevent scar tissue that can mess up absorption.
And the rule for mixing insulins in one syringe.
The mnemonic everyone uses is clear before cloudy. You draw up the clear, short-acting insulin like regular first. Then you draw up the cloudy, intermediate-acting insulin like NTH. That keeps the MPH from contaminating the short-acting vial.
And we teach kids to take over their own care eventually, right?
We do. Around age 8 or so, most kids are able to start participating in their own injections and blood sugar checks. It's really empowering for them and leads to better control in the long run.
What about diet? Is it super restrictive?
It's less about restriction and more about consistency and counting. We teach carbohydrate counting. The family learns an insulin to carb ratio, which is basically how many grams of carbs 1 unit of insulin will cover. This gives them a lot of flexibility in what they eat.
And for treating hypoglycemia, what's the two-step process?
Step 1. Treat the low immediately with 15 grams of a simple, fast-acting sugar, like 4 ounces of juice or some glucose tablets. Step 2. Once the sugar starts to rise, you have to follow it up with a complex carb and a protein like peanut butter or crackers. That second step prevents them from crashing again.
And what's the key advice for exercise?
Exercise is fantastic. It lowers blood sugar. But you have to plan for it. The rule is to give an extra snack before the activity and maybe during if it's prolonged. You almost never give extra insulin before exercise.
Are there any common medications that parents need to be warned about?
Yes, steroids, like prednisone for an asthma flare-up. Steroids will make blood sugar skyrocket. Parents have to know that if their child is prescribed a steroid, they need to be in close contact with the diabetes team to adjust their insulin doses.
Wow, we have covered a huge amount of ground here, from the pituitary controlling growth and water, all the way to the life or death protocols for DKA.
We really have. And if I could zoom out for a final thought for exams. Remember the opposites. DI is dry, SIADH is wet. And for DKA, please just burn that sequence into your brain. Fluids, then monitor, then insulin. The rationale for adding dextrose is all about preventing cerebral edema.
And we clarified that a child with GH deficiency is proportional. They're just small, a classic differentiator.
We hit the big ones. But let's end with a final thought, something to chew on that goes beyond the physiology. We talked about how adolescents with type 1 diabetes, they just want to be normal. They want to fit in.
And this disease forces them to be different, constantly checking, calculating, injecting.
Right, and that conflict between wanting to be like their peers and the rigid demands of the disease often leads to non-compliance. It's a huge challenge. So here's the thought. How can a nurse move beyond just lecturing about compliance and instead use technology like pumps or continuous glucose monitors to give that adolescent freedom and discretion? How do we align the medical needs with their very real psychosocial need for normalcy?
That shift in focus, from the perfect numbers to the perfect psychosocial strategy,
Yeah.
that's really what advanced nursing is all about. This has been an incredibly valuable deep dive. Thank you.
My pleasure.
Study smart, and we'll catch you on the next deep dive.